joining. I've mentioned before, this is a brand new topic. So it hasn't been presented before, even in the previous brachytherapy program that we ran a few years ago. So this is all new. We recognize that there was a need, I think, to discuss different imaging modalities and how we can implement and use all of those in the brachytherapy space. So this is really what this particular session is all about. So I'll get started. Okay. So over the course of this session, what we're going to look at is the selection of imaging modalities for HDR brachytherapy. And this includes imaging for applicator insertion and validation, and also imaging for brachytherapy treatment planning. So when we talk about imaging for gynae brachytherapy in particular, there are certain imaging modalities that we need. So these would be MRI, CT, ultrasound, radiographs, your traditional sort of imaging methods. I'm also going to briefly touch on things like photographs and drawings as imaging types that can also be really helpful in brachytherapy. And then what I'll also talk about is when do we need these particular imaging types? So be it before brachytherapy, during insertion of brachytherapy applicators, post-insertion, so for treatment planning purposes, and then also post-treatment. Okay. All right, so what we'll start on first is the different types of imaging in brachytherapy. So I guess MRI, magnetic resonance imaging, is what we now call the gold standard for brachytherapy imaging internationally. The beauty of MRI is it actually allows us to see the tumor. I remember when my department transitioned from doing CT-based brachytherapy imaging to MRI-based imaging, and the radiation oncologist I work with was so excited because he sort of said, wow, this is the first time I can actually see what it is I need to treat. So MRI is pretty amazing. And if you have access to it, I know it's not something that everybody has access to, even in more developed countries. So, you know, I'm very lucky that in my clinic, we have an MRI and we can use that freely. So MRI, like CT, provides us with a 3D image data set, so we can see complete volumes of the patient and different orientations as well. So you can get your coronal, your sagittal, and your transverse slices as well. So because with MRI we can see the tumor, so you can see in these images here, like this image over on the right, the brighter signal that you can see within the cervix there is actually active tumor in the patient. And if we look at the images down the bottom of the screen, this is the same patient that had a CT scan versus an MRI scan. And you can see in the CT, yes, we can see a cervix and we can see quite nicely, but we don't know where within that cervix and uterus we actually still have active tumor. So using that MRI image, we can actually see where the tumor is. And so we can make sure that we specifically target those areas in brachytherapy. So being able to see the tumor then allows us the ability to create these really customized and individualized treatment solutions for each patient. So rather than having the standard plan that we've talked about over the last couple of weeks with your tandem and rings and your tandem and ovoid, we can actually create far more customized treatment plans for each of our patients. One thing I have to stress, if you do have access to an MRI, you need to make sure that your treatment applicators are MRI compatible. So if you have an Electa system, it's usually the plastic type applicators that you can use in an MRI, and titanium applicators are also MRI compatible up to 3 Tesla MRI. But you need to make sure that your applicators are MRI compatible, that there's nothing else inside the patient that might not be MRI compatible, and so that your patient in general is able to have an MRI safely. Obviously, there's a whole bunch of safety issues you have to take into account with an MRI, particularly with those ferrous materials that could cause a lot of damage to a patient going through an MRI machine. So if you are going to transition into using MRI imaging for brachytherapy, you need to take a lot of care that everything that you put in the patient is MRI compatible and safe. So in terms of, can I go back? Yes. In terms of the parameters that you might use when you have an MRI of your patient, there are different image types that you can use. So with MRI being the gold standard for brachytherapy, the T2 weighted MRI images are what is considered to be essential as part of MRI imaging for brachytherapy. So the T2 weighted image set is what you would do your treatment planning on. If you have the ability to, T1 weighted MR images are also really useful. You can sometimes see the tumor necrosis and abscesses and any fistulas as well when you're doing your scan. So it might, having a T2 for your planning and a T1 that are fused together, you can then create an even better visualization of where your tumor is. In my department, if we have a patient that has interstitial needles as part of their gynae treatment, sometimes seeing those needles on the T2 weighted image set is really difficult. So we use a T1 weighted image set to visualize our interstitial needles as well for part of our treatment planning. I'm just watching the chat box while I'm talking as well. And I noticed Mohammed has asked a question about different TPSs accounting for tissue heterogeneity when using MRI. At the moment, the beauty of brachytherapy is that the brachytherapy dose calculation algorithm that we use doesn't incorporate tissue inhomogeneity. So if you remember from several weeks ago when we talked about calculation algorithms and treatment planning systems, the manufacturer dose calculation algorithm that is recommended to be used, the TG43 calculation algorithm, it doesn't take into account tissue heterogeneity. No matter what image data set you use, it's going to think your patient is really just a box of water. So at the moment, that's actually an advantage in brachytherapy over external beam planning systems, because obviously with the external beam, you need to have that CT data set to have the tissue and electron density information, but we don't need that in brachytherapy. So you can plan straight on an MR image in brachytherapy, which is really useful. When we're looking, when we're looking particularly at 3D data sets like MRI and CT, what we need to look for is a smaller slice thickness when we're doing our scans. So less than 5 millimeters is best, and actually probably 2 millimeters or 1 millimeter is the best if you can manage it. The reason we want smaller slice thicknesses is so that when we reconstruct our treatment applicator inside our patient, one of the most important things in reconstructing your treatment applicator is finding where the tip of that applicator is. And so if you have slice thicknesses of 5 millimeters, the accuracy of your applicator tip placement is only going to be within 5 millimeters, because you could have some interpolation between slices. So the smaller the slice thickness is, the better our applicator tip reconstruction will be. So that's why we sort of want smaller slice thicknesses as well. One of the benefits of MRI in particular is you can actually do scanning in oblique planes. So CT, obviously, you only scan your patient in the plane that the patient is lying on the bed. But with MRI, because you've got particular coils and things can be tilted, you can actually scan in an oblique plane. So in my department, when we scan our brachy patients with MRI, we actually take the image set in the plane of the applicator rather than in the plane of the patient. And that means that when we reconstruct our applicator and when we look at our images, they're already in the plane of the applicator, and it makes everything so much simpler than having to try and rotate images to see your applicator better. So I guess that's another advantage of having an MRI, is actually scanning in those oblique planes. I'm not sure whether all brachytherapy planning systems accept images in oblique planes. I know the Varian and the Electa systems do, but I can't guarantee whether the Bebic one does. But if anyone knows, you can type it in the chat, that would be helpful. One of the downsides of taking an MRI scan of your patient is that the scans can actually take several minutes. So depending on your slice thickness and depending on the strength of your magnet and a whole bunch of other things in your system, a single scan could take up to 10 minutes for your patient. So obviously during that time, bowel motion can be really big during your scan. And so what you'll see is actually the bowel then starts to look really blurry. So the two images you can see at the bottom of the screen, The one on the left is before anti-peristaltic medication is taken. So we give our patients a bus injection prior to their MRI scan, and that just reduces bowel mobility or motility for 15, 20 minutes, which allows us to take a scan to reduce those motion artifacts in the bowel. So the image on the left is before they've taken any peristaltic medication, and the one on the right is after they've taken the medication. You can see that the bowel is much clearer and easier to see, along with the cervix as well. So if you're going to do MRI images, it's often very helpful to give the patient some anti-peristaltic medication immediately prior to taking the scan. So moving on to CT, which I guess is probably the most common type of imaging used in brachytherapy, particularly for treatment planning globally. So even in Australia, CT is still far more common than MRI for brachytherapy. So obviously, like MRI, CT provides 3D imaging data sets, so you can get really great volumetric contours and images in your planning system. So CT is really useful for contouring your organs at risk. So your bladder and your rectum, your bowel and small bowel and large bowel, and your sigmoid as well. A CT is really good for applicator reconstruction compared to the MRI. So in the MRI image, the applicator is just presented like a black space in the patient, whereas in the CT, you can see that the applicators in this image up in the top right, you can clearly see your applicator in that image, and also the inside of the applicator as well. So you can actually see your source path through the patient, which is really helpful. So there are some departments that have access to MRI and CT, and they actually use both in treatment planning because they really prefer the applicator reconstruction on the CT than the MRI. So that's always an option if you have lots of imaging equipment to go around. So, and again, like the MRI, the small slice thickness, less than 5 millimeters, is best for brachytherapy planning purposes so that we can accurately reconstruct the applicator inside the patient. So another imaging modality that we can use in brachytherapy is ultrasound. And there are two different types. So you could have your transrectal ultrasound, your truss ultrasound, or you can have transabdominal ultrasound. Either one is okay for gynae brachytherapy. Sometimes it's radiation oncologist preference. Some prefer the transabdominal ultrasound so that they don't have to use the rectal ultrasound, which they feel sometimes deforms the cervix. And, obviously that's another thing inside the patient that then you have to try and work around, particularly when you're inserting the applicator. So my department uses transabdominal ultrasounds, but there are certainly a lot that use transrectal as well. So either one is perfectly okay. Ultrasound is great in giving soft tissue delineation. So you can see in these images, so that with the transabdominal image, you can actually see the bladder up the top, and then down here you've got your cervix and your uterus, and you can actually see the applicator side, the cervix and uterus in that patient. The transrectal probe image is probably not as clear because it's not an image that we're traditionally used to seeing. So it does take a little bit more time to learn and understand the images you see with a transrectal probe. But again, you can still see the tandem, you can still make out the soft tissue that would be your cervix and uterus. So it's still a useful imaging modality to have. One of the huge benefits of ultrasound is its portability. So you can have the ultrasound unit if you do insertions in a theatre or in a clean room. You can bring your ultrasound in there. You can bring the ultrasound into a treatment room to get a double check of things before treating the patient. Obviously, an ultrasound unit is a hell of a lot cheaper than an MRI. And so the portability of an ultrasound unit is really valuable in a hospital in general, to be honest. So you don't need dedicated scanning rooms. You don't have to worry about shielding or any of those issues as well. So an ultrasound unit is a key imaging device in brachytherapy. And obviously there's radiographs are quick, they're easy, it's cheap. Every hospital will have one or availability of one. Radiographs, like ultrasound, you only get 2D images, and you really can't get great soft tissue visualization So, looking at the images on this slide, I don't know where the cervix is. I don't know where, the bladder wall is, or the rectum or the bowel. So it makes it incredibly difficult to do any kind of dose optimization or customization for a patient to any great extent, because you really can't see what it is that you're treating very well. Radiographs are really good for point dose determination. So having our point A's and our bladder and rectum points that we've discussed in previous lectures. And like the ultrasound unit, the portability of, a radiographic unit is really valuable. So you could take that into the operating theatre, you could take it into a planning room, you could take it into the treatment room. You can get multiple images throughout the course of the patient's journey of treatment. So those things are super helpful. So radiographs do have a place in brachytherapy. They're certainly not completely useless. And I know we use a fluoroscopy unit in theatre, particularly when we're putting needles in our patient, just to double check where the needle is laying in comparison to other needles, as well as the main applicator itself. So we still do use your traditional radiography techniques as well in our department. And now, I guess, thinking beyond your traditional, medical imaging techniques, there are other types of images that are also really useful in brachytherapy. Obviously, photographs, you can just use your mobile phone, take a few photos. So this is quick and easy and cheap. And what photography does is provide good visualization of the external geometry of the applicator in relation to the patient. So it allows you to then quickly check the applicator position and orientation, where the applicator was at the time of insertion compared to when you're going to treat the patient, like immediately before treatment as well as immediately after treatment. So on our ladies here on the right, we've got a lady who's got a multi-channel cylinder just for a vaginal vault treatment. And we just draw marks onto the patient's skin for that particular insertion that line up to different parts of the applicator, so that we can check that the applicator hasn't slid out of the patient or rotated inside the patient to any great degree compared from when it was first inserted, where we were happy with its position, and then when we go to treat the patient, and then after treatment as well. If you've got a patient like the one at the bottom of the screen, for example, that has a lot of different interstitial needles, sometimes it's really difficult to know which needle's which. So often just a photograph with some references attached to that will also help you when you're connecting up your transfer guide tubes to the patient as well. So never underestimate the information that can be contained just in a couple of photos as well. And then the other type of image that we can have is clinical drawings. So again, these are quick and easy and cheap. So drawings, if you don't have access to a camera, or, ethics or hospital regulations won't allow you to take photographs of patients, you can just do a drawing of transfer tube connections if you need to. So my department, we take a photo and we also do a hand drawing of where the channels are in relation to each other and how they should all be connected up if we have patients with, more than 3 channels to connect up. So what we've got here on the right is a clinical drawing template. And this was developed as part of the Embrace 2 study. So you can actually download this from the Embrace study website, but I've actually got a PDF copy that will be provided to all of you after the presentation today. And so these clinical drawings are really useful, particularly if you don't have access to great imaging in your patient. So what you can do is then basically draw onto this template where your tumor is, whether it's infiltrative or exophytic, and then, dimensions of that. So you might be able to find if there's any vaginal involvement by doing an examination of the patient, and you can sort of measure finger widths or, 3 o'clock to 9 o'clock position in the patient, and then you can draw that onto your clinical drawing. Maybe you've got access to an MRI machine, but you can only access at once for the patient. So maybe a pre-brachytherapy MRI, you can use that then to create a clinical drawing and take that into the theatre or wherever you insert the applicator and wherever you do planning, to then help guide you as to what sort of volume you need to be treating on your patient. So this is just some examples of what a clinical diagram may look like. So on the left here, we've got a clinical diagram of a patient at the time of diagnosis. So you can see that the tumour is quite large. It goes quite a ways down the anterior vagina, and then there's some parametrial involvement on both sides of the patient as well. And then at the time of, and you can also see on this page that we've got some dimensions. So the width, the height, and the thickness of the primary tumour as well, and how far down the vagina the involvement extends. And then over on the right here, we've got a diagram of the same patient at the time of brachytherapy. So after they've had a course of external beam radiation, we can then see that there's been a regression of the tumour within the cervix. The involvement down the vagina has been reduced, and we've just got some tissue hardening in the vagina as well. So that may not be true tumour, it may just be a response to external beam as well. So those images are really powerful tools when you then come to plan your brachytherapy treatment, because you can basically draw in a high-risk clinical target volume based on the measurements that you have here on your clinical drawings, without having, an MRI image to plan on, or, any other sort of sophisticated imaging. So even these things are really useful tools. And as part of the Embrace study, they mandate that and the Embrace study is about every patient having MRI imaging at treatment, but they still require you to draw those clinical diagrams as well, just as an extra source of information for the planner and the department and everybody involved. So we're just going to do the first poll question. So I will stop sharing.
Okay, great. I'm launching the first poll question.
Great. And if anyone has any questions, please ask. So the question is about, if you take an MR or CT scan of a patient with the applicator inserted, why do we want a thin slice thickness of less than 5 millimeters? So is it to see the tumour better, to see the organs at risk, to see the applicator better, or to be able to place our dose points more accurately?
Okay, we're getting some answers. We'll give it another 30 seconds or so.
Mm-hmm.
Okay, we'll close the poll in a couple seconds. It's okay if you didn't get to answer the question, no worries at all. And I'm gonna end the poll now. All right.
Okay. Oh, it's close. There was 2 answers that people kind of thought might be right. Okay, let me share my screen. We can go back to that one. All right, you can see my screen. Okay, so the correct answer is, oh, did I hit that? All right. So you can see the poll results. Is that right? Is that right? I don't know what I'm sharing anymore. Let me.
Well, I can stop sharing the poll results.
Okay, perfect. Okay. Oh, sorry, that's just popped up. Okay, so the answer to this question was C. So to be able to see the applicator better. So as I've mentioned before, we need to be able to reconstruct our applicator in our treatment planning system accurately to within 1 or 2 millimeters. And so the thicker slices, so more than 5 millimeters, you'll have some inaccuracies in determining particularly where the applicator tip is. So that was the answer for that question. Obviously, a thinner slice thickness, you can probably see the tumor better and the organs at risk, and you can place your dose points more accurately. But the main reason is about finding the tip of that applicator, particularly, for example, if you have interstitial needles and they're super small tips, and often, the dead space at the top of the needle might be only 2 or 3 millimeters. So if you're 5 millimeters off from the tip, it means your first dwell position is going to be 7 or 8 millimeters away, which means you could be missing some of the tumor that you need to cover. So that was the answer to that one. All right. So for the second part of the presentation, I'm going to talk about when we use imaging in brachytherapy, and then what types of imaging would be, the best ones to use for each of these different stages in brachytherapy. So there are different moments during a patient's brachytherapy journey that we can use imaging. And I guess for me, the more frequently we get image information from our patients, the more accurate our treatments can be, and the more customized we can make them for that individual patient. So we can make sure we are covering the whole tumor at the time of that particular treatment, and that we, that we actually did what we planned to do for each of our patients. So the first stage in a patient's journey is really pre-brachytherapy, particularly with cervix cancer. Our ladies will have had external beam radiation therapy. So obviously you will have imaging from your patient at the time of diagnosis. We've had an image, we can see they've got cervical cancer, and then we do our external beam. And so, maybe when you do external beam radiotherapy, the only imaging you've got is that CT scan or those radiographs that you've planned with on your patient. That's fine. But really what we need to do is then get another image at the end of external beam, just to see what's happening inside our patient. After 40 or 50 gray of radiation therapy, what tumor was there before treatment is going to look quite different to the tumor that is there afterwards. And so by knowing what tumor is left in the patient before we start brachytherapy will help us decide what kind of applicator will best meet the needs of that patient. So whether we need to have an interstitial treatment, whether the tumor is so big and bulky, we really can't cover it very well with just a tandem and ring or a tandem and ovoid. So, getting that image before brachytherapy will help us decide if we need to have needles, and maybe how many needles we should have, and maybe how deep those needles should be inserted in the patient as well. So you can go into the brachytherapy insertion stage fully aware and fully equipped for what you need to do for that patient. The other thing is about insertion ability. If your patient has a very large bulky tumor that hasn't responded well to external beam radiation, maybe you're not going to get an applicator inside the patient anyway, and brachytherapy might not be an option for them, and they may have to have more external beam. So again, just that image that you can get of your patient after external beam or close to the end of external beam is really helpful in then planning how you're going to attack the rest of the tumor for the brachytherapy phase. And there are different options you can have for pre-brachytherapy imaging. So it could be just your clinical diagram that could be completed just as part of a physical examination, or it could be completed in conjunction with other imaging types as well. If you don't have options for a lot of different imaging techniques, even just a physical examination so that you can see, whether there's still vaginal involvement, whether the cervix is visible, whether you can see the os in order to get a tandem inside. Those things you can find out just with a physical examination and put those on a clinical diagram. MRI obviously is our gold standard. It's our best option to really see what the tumor looks like inside our patient, but obviously that's an expensive option that a lot of people don't have access to. You could take a CT. In a CT, you should be able to see if you've had a large tumor and if there's been any regression of that large bulky tumor. And ultrasound is always a good option as well, particularly if MRI and CT are unavailable, because again, you'll get that soft tissue visibility and you'll be able to see how the tumor's regressed from the external beam radiation. The only one that I probably wouldn't think is very useful is radiographs at this point, because you've got no internal markers and you're not going to see any tissue, so you're not going to know if there's been regression from a standard radiograph image. So this is just an example of MRI images that were taken of a patient over the course of their external beam radiation therapy, just to show you how much a tumor can regress. So before they started external beams, they'd received 0 gray. The GTV had an initial volume of 75 cc. So the GTV is the red contour that you can see, and the CTV is the green. You can see even after 9 gray, the tumor is already starting to shrink inside the patient. After 18 gray, it's smaller again. 27 gray, we're getting smaller. 36, and then at 45, just before you start doing brachytherapy, the residual size of the GTV is 8 cc. So it's been reduced by almost 90% of its original size, which is fantastic for this lady. And it then gives you an idea of how small your high-risk CTV is going to be. And, maybe we don't need to put needles in this patient, and maybe tandem and ovoids is going to be the best option. But if you based your brachytherapy on the diagnosis image, or that 0 gray image, you'd be thinking, yes, we need needles, and yes, we need to do all this, because it is such a big tumor. So those images throughout treatment are really, really useful to make sure that you're in the right space before starting brachytherapy. One of the important parts of imaging is actually imaging during the applicator insertion. Now, I'm not a radiation oncologist. Thankfully, I don't have to do the applicator inserting. I'm in awe of the radiation oncologists I work with that do, how they get everything into the right place. But even they say they wouldn't be able to do it without being able to see. So this is where imaging really plays a major role in brachytherapy. So there are a lot of reasons that we want to image during applicator insertion. So one of those is to ensure that the tandem doesn't perforate the uterus as you're doing the insertion. Another one is to ensure that the tandem is the correct length and the correct angle inside the patient. And also, if you're doing any interstitial needles, it's really helpful to validate that they've been inserted into the depth that you need them to be inserted. So the options for imaging during applicator insertion, the best option really at this point is ultrasound, because you've got that great soft tissue visualization. It's real-time imaging. So you can be inserting the tandem and you can watch it as it goes into the cervix and into the uterus. It's super helpful. And then you've got fluoroscopy or radiographs. Again, at that point, you can't see soft tissue well, so you're really not going to be able to tell whether you've perforated the uterus or if you've got the tandem in the correct place. We use fluoroscopy just for the interstitial needles, just to make sure they've gone into the right depth, because they're a little bit more difficult to see on a regular ultrasound, but we still use ultrasound as well as the fluoroscopy in those cases. So during applicator insertion, ultrasound is my imaging modality of choice. And again, the portability of ultrasound is really helpful. So wherever you're inserting an applicator, you can have an ultrasound unit in the room. It doesn't have to be a shielded room, all of those kind of things. So the only issue I would say with ultrasound is it's very operator dependent. So you need to make sure that whoever's doing the ultrasound, whether that be, a specific sonographer, or whether that be a radiation therapist or a nurse that have been trained to use the equipment, that they are well trained to use it, and that they understand what it is you need to see to do your job correctly. So there needs to be some really great communication between those two teams so that they're getting the images that you need during the applicator insertion. So again, in this ultrasound image, you can clearly see the bladder. This bright line here is the tandem as it's being inserted into the uterus, and you can see the uterine wall and a little bit of the rectum down the bottom as well. So it's a really nice image of our patient and our applicator. So just a couple of examples here of how an ultrasound can be super helpful during the insertion. So figure A, you can see the tandem is not going down the uterine channel. So here's the tandem here, and this is the uterine channel that it needs to be going into. So it could be that the angle of the tandem is not right, but to me it looks like what's happening is the applicator is starting to form a false passage. So you'll end up having a false, I guess, pathway through the uterus. which is not helpful and could ultimately lead to a perforation. So you can see it also in this image set, because you can see the image of the center of the uterus or the uterine canal is flat. There's nothing inside it. So you can see that your tandem isn't inside the uterine canal in this particular slice here. So in figure C, we can see whatever happened has, maybe they've changed the angle, but the tandem is now going down the uterine channel. And this is also confirmed in this view. You can see the uterine channel and the tandem overlaid on top of each other. So we now know that our tandem is in the right spot. And this is really where ultrasound is so helpful. You know, it takes a little bit to interpret the images of what you're seeing, but once you know what it is that you're seeing, the information that they give is really, really valuable. So post-insertion and imaging for treatment planning is probably, well, it's obviously the most important imaging that you have. You can't plan a treatment without any images. So this would be the most important image set. And then I would say the insertion image is your second most important image set. So when we're doing imaging for treatment planning, there are things that we need, information that we need in order to create a really great plan for our patients. So we need to be able to see our applicator inside the patient, and we need to be able to see the tumor, or at least the cervix and the uterus of the patient. We need to be able to see the organs at risk. And in some cases, this may require multiple imaging methods to get all of that information for our patients. So there are different ways we can do this. So we can have MRI only. You know, MRI gives us great tumor visualization, the best, gold standard. MRI allows us to see our organs at risk. You can see the treatment applicator in an MRI. It's not perfect, but you can see it. So you can plan purely on an MRI data set. The only, you can see the treatment applicator really well. You can see the cervix and the uterus, not so much the tumor, but that's okay. And you can absolutely see the organs at risk. So CT only is a great option for treatment planning. Radiographs only, well, you can see treatment applicator. You can use the radiographs to create your organ at risk dose points. So you can have your bladder dose and your vaginal rectal dose and your point A doses for prescribing, but you really can't see the organs at risk, and you really can't see the tumor or the cervix or the uterus. So it's an option. It's not the best option. What we could have is ultrasound plus CT or radiographs. So ultrasound allows us to see the tumor or the soft tissue that we need to see, that we can't see in our CT and that we can't see in our radiographs. So by combining ultrasound with another of the imaging modalities, we can actually get more information and create a better plan for the patient. And then obviously we've also got our clinical diagram, which is always super helpful regardless of what imaging modality you use. So you could use any of the above options and then add your clinical diagram as well to give you that extra information for your treatment plan. So if we were going to treat or do a treatment plan with MRI only, contouring of the high-risk CTV and the organs at risk are really simple. You know, you can see in this image down in the corner, there's your high-risk CTV, or that's your GTV, because you can see it's brighter. That's actual tumor. And then the purple contour is your high-risk CTV, because it's your cervix and any residual volume that you need to have. You know, you can clearly see the bladder, you can clearly see the rectum, all of that, super simple. What's challenging in the MRI is applicator reconstruction. So in an MRI, applicators appear as black spaces in the MR image. So what you can do is use a fluid-filled MRI marker. So the wires that you'd use in a CT are useless in an MR. Again, they're just going to appear black, so they're not going to help you. So you need an MRI compatible marker to define the source path. So this is what this line that you'd see in this image is. The fluid-filled MR markers are sometimes difficult to insert in the ring applicator because they're fluid filled. They're a little bit thicker, so they don't bend around a ring quite as easily as a wire marker would. Because they're thicker, they don't fit in interstitial needles at all. I currently have a resident physicist trying to create thinner markers for our interstitial needles at this point, but not having much success. So there are a couple of problems. Another problem with MR imaging for treatment planning is if you use the titanium applicators, sometimes you can get imaging artifacts. So you can see in the top right corner here of the slide, we've got a CT of a phantom with an applicator in it. And here's an MR image of the same applicator. And you can see with titanium, particularly at the tips of the applicators, you get these imaging artifacts. So again, accurately defining the tip of the applicator can be a challenge. And you can also see that there's some artifacts around the ring part of the applicator as well. So that's just something to be aware of if you have titanium applicators. What is very useful if you're going to do MRI only treatment planning is the applicator models. So we can see down the bottom of the slide, we've got like a 3D model of what our applicator geometry should be. And we can fit that diagram of the applicator over the black space that we have in our MRI image to place our applicator inside the patient for the plan. So I probably wouldn't suggest any department moves to MRI only brachytherapy treatment planning without having applicator models available to them. I think it's just a little bit too difficult, a little bit too risky to reconstruct an applicator without an applicator model. So that would be my advice if anyone was thinking of moving to MRI only. If you don't have applicator models, the alternative is you have an MRI and your CT and you fuse the two images together and you reconstruct your applicator on the CT, and then you have all your volume contours on the MR and you join them together in that way. So if we were doing a CT only based treatment planning, applicator reconstruction and organ at risk contouring is simple. It's very easy to see the applicator in a CT. It's very easy to see the bladder, rectum, sigmoid, small bowel, all of that in a CT. The challenge in a CT only based treatment planning is contouring the target volume. So your high risk clinical target volume. That's the challenge with CT only. What we've found, and there's been several studies published, is that if you try and contour on a target volume on a CT data set, the volume will almost always be bigger than if you contour the volume on an MRI. So you can see in these images, we've had a radiation oncologist contour what they thought the high-risk clinical target volume would be on a CT on the left. In the middle image, they've contoured a high-risk CTV on an MRI image, and you can see the two overlaid on the right-hand side. And the CT volume is always bigger than the MRI. And what this means is if you're trying to optimize and cover your high-risk CTV, it means that your organs at risk are going to get more dose because you're actually trying to cover a bigger volume than you actually need to be covering. So I guess that's something to be aware of if you are going to do CT only based planning, is that yes, you can see a cervix and a uterus, but what you contour is often bigger than what in reality you need to cover. So it's just something to keep in mind. In that case, having something like the clinical diagram that we've talked about can also be really helpful to better define the dimensions of the high-risk CTV. So in that case, you might have the width from your clinical diagram, and you can compare that to the contours that you've drawn on your CT data set, just to make sure you haven't gone wildly off with your contours. So another option is having ultrasound. And so ultrasound is really helpful in giving an accurate estimation of the high-risk CTV size. And there's been a lot of studies recently that have shown that when you contour the high-risk CTV on an ultrasound image, it's a better match to the MRI, which is our gold standard, than the high-risk CTV that's contoured on a CT. So I was actually saying contouring your tumor on an ultrasound is better than contouring it on a CT. So, which is exciting. I think it's great because ultrasound units are cheap and portable and easy to use, and and they're giving results that are comparable to an MRI in terms of high-risk CTV contouring. So I think that's pretty amazing. So what you can do is, if you have ultrasound and you have a CT, you can use the dimensions of your ultrasound to draw the high-risk CTV onto in the planning system. And again, I talked about transrectal ultrasound and transabdominal ultrasound. Again, you can use either of those options to get those dimensions of your high-risk CTV. So, and there are various papers that talk about transrectal and various papers that talk about transabdominal, and both of them show really great results. So what you can see in these images is we've got transabdominal images. You can see that you've got your cervix and uterus here, and they've just taken measurements from one side of the cervix to another at various locations. And then you can translate those onto your CT image in the treatment planning system. So I think that's a really great option for departments that don't have access to an MRI. So I think, for you guys that are doing brachytherapy, if you have an ultrasound unit, I think it's a really valuable and powerful tool to use for brachytherapy. So it hasn't got the credit it deserves in previous years. So this is just another example of ultrasound images compared to an MRI. So you can see the ultrasound image here. And again, it is operator dependent. You've got to have a good operator of the ultrasound unit to get the quality images that you need. But you can see that they've measured, the length of the tandem and various distances within the ultrasound image, and comparing that to an actual MRI and how well they match to each other. And then this is a transverse image of the cervix here and transposed onto an MRI data set there. So you can see how well they do match to each other and how useful ultrasound can be. Another option is using ultrasound and radiographs. And I guess this is a similar method to using ultrasound and CT. However, you're not going to have the great volumetric definition of your organs at risk that you do with a CT scan, but you can include those measurements from the ultrasound images that you take in your digitized and reconstructed plan from the radiographs. Your applicator, you can then put dose points in along the distances that you've measured using your ultrasound unit. So this will at least allow you to cover the high-risk CTV for an individual patient, maybe a little bit better than you would have otherwise. So it will still be very helpful. There is one big word of caution if you are using ultrasound for treatment planning purposes, is you need to make sure that the ultrasound unit is regularly calibrated, because you're going to be using your ultrasound image in your planning system, and you're going to be putting distance values in. You need to make sure that the distance values the ultrasound unit gives you are accurate. So you need to make sure that ultrasound unit is calibrated. There are phantoms that you can purchase, or you could make a phantom in-house, just to make sure that if your ultrasound unit says that this distance here is 1.5 centimeters, that actually is what it is. So I can't stress that enough. If you're going to be relying on measurements from an ultrasound unit, you need to make sure those measurements are accurate when you put them into the treatment planning system. So the other imaging that I would say is probably less important, although still useful, is doing pre-treatment and post-treatment imaging. So when I talk about pre-treatment, I mean like taking an image immediately before you turn the machine on. And so by doing that, you're verifying that the applicator is still in the same position as it was for your treatment plan. Okay, so this is an image immediately before treatment commences, and then perhaps another image immediately after the treatment finishes to validate that the applicator hasn't moved over the course of treatment. So you're then more confident that the the plan you've created is the plan you've delivered to your patients. So there are some simple options to do this. There's obviously complicated options. Running a patient through an MRI scanner or taking a CT is probably a complicated option, which also involves shifting patients on and off couches. So it's not really the best option. So options for this again is, referring to photographs of external applicator positions against the patient's skin that's taken immediately after the applicator was inserted inside the patient. And another option could be radiographs. So a radiograph taken at the time of insertion overlaid against a radiograph taken immediately before treatment, just to make sure that the applicator is still sitting within the same frame of reference inside the patient. So again, that's quite a luxury thing to do. And I must admit, I don't do it in my department. We have the photographs, which is what we compare to, but we don't take any other images. We don't take radiographs of our ladies before or after treatment. But I think it would be good practice to do so. It's just obviously the options that I have in my department limit that. But we do have the photographs and we do refer to those pre and post treatment for our patients. So I've just got one more poll question for you. So I'll stop sharing.
Should be launched.
All right. So there's a lot of words in this question. So you might need a little bit of time to read all the answers. But the question says, if we're using CT images for treatment planning, what are the issues involved in contouring our high-risk clinical target volume? And how can they be resolved? Okay, so the options for answers are: there are no issues. You can see the high-risk CTV with a CT. Second one is high-risk CTV can't be accurately seen and produces a larger volume than using MRI. You could use measurements from an ultrasound to help guide you. Third option is high-risk CTV can't be accurately seen and generally produces a smaller volume than MRI, and you must have an MRI to accurately contour. And then the last option is you don't need a high-risk CTV, you can just use 0.8. So I see a trend already.
Yes. I think people have a pretty good sense of what they think is up. Awesome. We'll give it another 10 or so seconds.
All right. Maybe the question is too easy.
No, you teach very well. That is it. Okay, no worries if you didn't get a chance to answer. I'm gonna go ahead and end the poll, and then we can see the results of what everyone thought.
Okay. I think it was overwhelming, the response for part B of that question. So I'll just start sharing again. Okay. So yes, you're all right. Well, most of you are right. So in that poll question, so the high-risk CTV can't be accurately seen in the CT. MRI is your gold standard. Okay. And we also saw that if you try and contour a high-risk CTV in a CT, you generally get a volume that's larger than that of an MRI. And so we've also seen that an ultrasound and an MRI actually produce volumes that are quite similar. So in that way, we can use measurements from our ultrasound unit to provide a more accurate high-risk CTV on our CT data set. So, and question C is kind of right, but you don't need to have the MRI to accurately contour the high-risk CTV. That's when we can use our ultrasound. That's when ultrasound becomes a really powerful tool in a department, particularly for brachytherapy. So I'm glad. I think most of you kind of got that message, which is really great.